On-the-scene coverage of ACC 2015 is supported by Effient.
I'm Peter Block here in San Diego at ACC 2015 for On the Scene. To my left is Dan Mark from Duke. And Dan has been involved in a trial here at ACC which has generated a ton of interesting, not controversy necessarily, but what is going on and what should we take away from this trial. But Dan has talked about the economic side of the PROMISE trial. So let's talk about the economics a little to start with, Dan, and then we'll talk about what PROMISE actually means. So you looked at the cost of all this. What did you find when you looked at those data?
Well, the cost of the actual testing strategy itself was somewhat predictable. I think the CT angiogram cost about $400, including everything. The echo strategies, the stress echo was about $500, and the stress nuclear was between $900 and $1,100 to get the test done. And stress ECG, of course, was less than $200. Once you looked at the downstream effects of testing and included the things that happened because the test was done, one functional or anatomic, the positions of those test strategies changed. So what we saw was that there was more invasive testing in the CT angiogram arm and more revascularization, although there was also somewhat less follow-up non-invasive testing. And the net effect was to have about a $300 higher cost at 90 days in the CT angiogram arm than in the stress nuclear arm, which was not statistically significant.
As I've talked to people about PROMISE, and I'm sure you have as well, the interpretations of all of that vary so much. Some people have just taken those data and said, well, why don't we just do CT angiograms on most of the people or all of the people that we see, because that seems the best way to get some downstream strategies sorted out properly. What's your response to that?
It's interesting. I've been in meetings where people say, why do we do any testing at all? I think that none of what we've done so far releases people from the requirement to exercise judgment. Doctors have to first figure out what's going on with the patient and whether the patient has sufficient reason to go on to a diagnostic test. And that was a population that we tried very conscientiously to isolate, not just all comers with wild stories, but people who had serious chest pain, were coming to the doctor because of it, and the consideration was that there may well be active coronary disease as the cause of this, and something needed to be done. And that was where we started. So, and then the issue of how to decide what to do from there, I think what PROMISE has shown is that both strategies are viable and end up pretty much in the same point from the patient outcome perspective, as well as from the cost perspective.
Well, the flip side would be, well, why not do nothing at all? But I think your point about clinical judgment rules is an important one and still gives us the opportunity to make choices. So the other side of this, though, Dan, is that it does put CT angiograms in a little better position than we usually have thought of it in the past. Is that probably an appropriate statement to make?
Yes, I think so. I think that before PROMISE, there was a lot of anxiety in some quarters about what widespread CT angiography testing would do to patients. And while some people thought that it would improve the efficiency of care, and we would only send for invasive angiography those people who actually needed revascularization and avoid all the normal casts that we now see, other people said, no, this test is going to give you a lot of ambiguous findings. You're going to end up doing stress nuclear studies to clarify them, and then you're going to send them to the cath lab. They're going to end up with way more radiation exposure, more testing, more expense, and it's not going to be good. And so I think PROMISE helps to put some real numbers where there was simply fears and concerns.
Perfect. So I guess I should sort of summarize by saying the good news here is that clinical judgment still prevails. That's not a bad thing, is it, Dan?
Not at all.
And the second thing is that although CT angiograms now come up in terms of our thinking about them, it isn't necessarily the end-all and be-all, and we still should make the best judgment using what we have at hand.
Absolutely.
Thank you, Dan.
100%. Thank you.